Hello there, my name is Chandra Ori. I'm a consultant in respiratory medicine with an interest in bronchiectasis and cystic fibrosis, and I work at Glenford Hospital in Leicester. Today we're going to talk about bronchiectasis causes and presentations. During the talk, I'm going to give a little bit of an introduction talking about the history and definition of bronchiectasis, but the main focus is going to be a series of cases which highlight different presentations as well as key aspects of patient assessment that we should be doing in our bronchiectasis clinics. And of course, by covering those sort of case examples, we'll talk about causes and key investigations. So in terms of history of bronchiectasis, well, Linnet, who is responsible for a lot of discoveries with respect to respiratory medicine, was also the sort of person who identified bronchiectasis as an entity in 1819. And he described the condition through a series of case reports, especially looking at patients in post-mortem. And he also made the connection between an illness characterized by chronic sputum production, as well as previous infections such as TB or whooping cough, and linked that and then labeled the condition as bronchiectasis. So bronchiectasis, as we all know, is chronic dilatation of one or more bronchi, and these bronchi exhibit poor mucus clearance, and therefore people are more likely to get infections, whether they be acute or chronic, relating to bacteria. Radiologically, the definition is very useful to use in clinical practice. So that states that we've got bronchial dilatation, which is bigger than the adjacent blood vessel, and also bronchial wall thickening. And that dilatation of the bronchi bigger than the adjacent blood vessel equates to what we know radiologically as a signet ring sign. So clearly bronchiectasis is defined anatomically by CT scanning, but the question is, how do we recognize the clinical syndrome? And that can actually be quite difficult, because these are the kind of symptoms which people with bronchiectasis may have. But there's no combination which is particularly pathognomonic for bronchiectasis. So very common symptoms include chronic cough, daily sputum production. Common symptoms include also breathlessness on exertion, hemoptysis, nasal symptoms, pain, fatigue, and some of our patients less frequently also have wheeze. But these are not particularly specific. So it's useful to think about different patterns of presentation. And that's kind of the thing we're going to focus on in our series of case examples. So the first case example is a 64-year-old man who's already been diagnosed with bronchiectasis on CT scan and is referred by another respiratory physician into the specialist bronchiectasis clinic for us to take over his care. So whenever we're assessing any patient, even if they've been worked up by other colleagues before, it's important in the initial consultation to get as much detail as we can, and there's certainly key questions which help in relation to that. So it's worth just thinking about what are the key questions that you would like to ask if you were taking a history from a fresh patient who has been referred into your specialist bronchiectasis clinic. The kind of things, as we know, which are important are to establish the duration of symptoms. So how long have they had the symptoms or infections for? We clearly want to go back into childhood as much as we can to get a sort of long, detailed history as possible. So in this example, this patient's had symptoms for about 11 years. So the next question is, well, what happened 11 years ago? What is it that triggered off the patient's recurrent symptoms? And from this example, the patient had pneumonia 11 years ago. So obviously we know that post-infectious causes are sort of fairly common when we think about bronchiectasis. And then clearly we want to ask, what symptoms do you get when you have an infection? This is a useful question because sometimes a patient's understanding of what an infection or infective exacerbation may not be the same as what we think it is. And therefore it's important to clarify what the patients understand, they're talking about when they actually describe infections. So in this case, the patient describes sputum going from clear to green with increased cough, which very much does sound like infective exacerbations. But I have had other patients, for example, they think that things like wheeziness or a little bit of shortness of breath and exertion equates to an infection, and that's not necessarily always the case. The next thing we want to ask our patients clearly is, do they get breathless? And if so, what's the exercise tolerance? And try and calculate MRC Dismal score. In this case, there's no suggestion of breathlessness. This patient currently has an unlimited exercise tolerance. We want to know how much sputum they're producing, if it's daily, what kind of color it is, and consistency as well of the sputum. So in this case, the patient's producing about 10 to 20 mils per day. It's white. In terms of consistency, they say that they can sometimes get sticky sputum, which is difficult to expectorate. And that's useful to know, particularly when we're thinking about physio airways clearance management, because it can influence the types of modalities that we use to help with airways clearance. Obviously, you have a separate talk from our physiotherapy colleague, which will focus more on that. Clearly want to know about any other associated symptoms. So hemoptysis clearly is common in bronchiectasis, wheeziness, chest pain. This patient doesn't have any of those features. Do they have any weight loss or fevers, which is important with systemic disease, but also can sometimes give clues to the cause of bronchiectasis. But in this case, there is neither of these. Do they have any nasal symptoms or hearing loss or ear infections? These are important, particularly when we're thinking about conditions which can have upper airways involvement, such as primary ciliary dyskinesia or even cystic fibrosis. But in this case, the patient doesn't have any of those. And also we want to find out, if they're having infective exacerbations, how often those have been, on average over the last year or so. Have they needed antibiotics? If so, which antibiotics? How many days of antibiotics have they been given when they get infective exacerbations? That's very useful to think about, in terms of treating infective exacerbations going forward. But also the frequency of infection will influence in due course whether or not we think about long-term daily antibiotic prophylaxis as well. And clearly it's worth establishing at the first visit, does the patient have any airways clearance advice? Have they been shown what to do or told what to do by an expert physiotherapist previously? And if not, clearly that's something we need to establish immediately. And then, of course, to finish off, the usual rest of history, we want to think about past medical history, drugs, etc. Thinking specifically about review of systems, there are a few questions which can certainly give us clues as to what may be the underlying cause of bronchiectasis, and it's definitely worth asking all of our patients specifically about fevers, weight loss, joint pains, other system infections such as urinary tract infections, altered bowel habit, dysphagia, or any features of aspiration or dyspepsia. And again, if you've got somebody who's had lifelong symptoms, thinking about things like failure to thrive, particularly in childhood or younger life. So the patient, as we said, had an HRCT scan which did confirm bronchiectasis. We already know that. So therefore, we need to think about, what are the appropriate investigations. And there's a sort of general approach which we can use. Essentially, all patients should really have the top items on this list done. So, they should all have blood testing for immunoglobulin levels, ideally an HIV test as well, and also blood testing for ABPA, allergic bronchopulmonary aspergillosis. All patients need to have clearly sputum for microbiological analysis for both routine culture but also non-tuberculous mycobacteria. And then we have quite a few other investigations which I wouldn't necessarily do these all as a routine on all of my patients. It kind of depends on what aspects you've teased out from the initial history. But certainly it's worth considering all of these in all cases as to whether or not it's appropriate to do each of these. Alpha-1 antitrypsin levels, particularly if you've got patients who also have emphysema or if they're younger age. Rheumatoid factor, clearly if you've got anyone who's got joint pains or discomfort. Autoantibodies may be relevant. And of course, we're going to consider CF testing or primary ciliary dyskinesia testing in our younger patients, but also particularly, as we said before, if they have those upper airways, nasal, ear problems of note. We might think about doing a bear and swallow or esophageal studies, particularly if our patients have features of aspiration, or even in patients with severe features of gastroesophageal reflux disease, we might think about doing those esophageal pH studies. And clearly, all patients should be having spirometry, but, it's a useful test, but it's not diagnostic. And particularly recently with COVID, we've not been able to do as much spirometry as we like. But certainly when the opportunity avails itself, we should be getting some at least baseline spirometry. Certainly at the first visit, if that's possible. The general approach really in terms of patients such as this case one who seems to have a post-infective cause for bronchiectasis, first thing really is to establish proper physio and airways clearance. Clearly we want sputum sampling, we want to exclude any underlying immunodeficiency or any other causes of bronchiectasis that we think may be lurking. And clearly the patient needs to have some sort of self-management plan for infective exacerbations, supportive mechanisms such as flu and COVID vaccines, and then of course in due course we may consider long-term therapy such as daily antibiotic prophylaxis if there's a high infection frequency. But the main focus of this talk is not specifically on management, and there'll be another talk relating to sort of the management of bronchiectasis. So thinking about microbiology, what are the common sputum organisms found in patients with bronchiectasis? Well, the common ones that we see are Haemophilus influenzae, Pseudomonas aeruginosa, Moraxella, and Staph aureus. There are less common organisms, but I have to say these are maybe less common, but actually they're still fairly common if you work within a large cohort of bronchiectasis patients. So things like MRSA, Stenotrophomonas, and of course the non-tuberculous mycobacteria. There's a variety of these, many that we come across, but the more common ones are particularly avium and abscessus. And of course, fungal infection can be very relevant and important, particularly Aspergillus and Candida. And we occasionally come across an organism which historically has been more common in people with cystic fibrosis called Burkholderia. And we do have the odd patient with that, but I have to say I've not seen that many cases recently picked up as new diagnoses. So it is important that all patients have self-management plans, and clearly, physio recommendations are going to be paramount with respect to that. We'll be guided by the sputum microbiology in terms of what antibiotics we recommend as first-line treatment for infective exacerbations, and it's important to state that as per BTS guidelines, we should be using 10 to 14 days of antibiotics, and that's important that the patient knows that as well as our primary care colleagues. And then clearly, it's important that patients are given contact details for specialist bronchiectasis teams, particularly if those oral antibiotics are not helping and we might be considering IV antibiotics as the next step. So defining an exacerbation is important. And again, as I kind of alluded to before, sometimes a patient's definition of what they're having as an infection is not always the same as what we may consider to be an infective exacerbation. And therefore, this is a pretty useful statement that came out a few years ago by a sort of consensus of experts, which is very useful, and I use this on a sort of a regular basis to try and make sure that our patients, but also other non-bronchiectasis health professionals such as GPs, are aware of what we're thinking about in terms of the benchmark that we suggest, when patients should start using their rescue packs of oral antibiotics. Okay, the next case is a 22-year-old woman who has had a history of lifelong chest infections. So immediately that should be ringing alarm bells as to a genetic cause of bronchiectasis. And she was admitted to the special care baby unit at birth with respiratory distress noted at that time. Now she's producing about 30 mils of yellowish sputum on a daily basis and has had 4 to 5 chest infections per year over the last few years. Normally, no shortness of breath, but definitely finds that things get worse with an MRC dismal score of 2 during infective exacerbations, and has had a definite history of previous ear infections and bilateral hearing loss as well, which has been confirmed on audiometry. So there's a lot of things really in this story which are pointing towards a likely suggestion of something that we call primary ciliary dyskinesia. And really, the nasal symptoms are there. So the next steps really need to be sort of excluding or proving a diagnosis of primary ciliary dyskinesia. So the way that we do that is nasal nitric oxide, and that's our sort of first step in terms of investigation. If that test is abnormal, then patients will go on to have a nasal biopsy and ciliary examination. So it's called a nasal biopsy. It's strictly speaking more like a scraping, and it provides that scraping provides cells which our PCD experts can then look at on slides under microscopy, and they actually look at the way that the cilia function under the microscope. If that proves to be negative, in other words, there's no evidence of PCD, then we should be thinking about other genetic causes, and clearly cystic fibrosis is the other common condition. Otherwise, we embark on our standard investigation protocol as well if we didn't find anything from our genetic analysis. But clearly from this story, it really does sound like this patient has PCD. And in terms of primary ciliary dyskinesia, just so that we know what's the pathophysiology, well, this is a sort of cross-section of a normal cilia, which can be anywhere in the respiratory tract. And the main structure of the cilia is 9 sort of microtubule doublets, but also these dynein arms, which essentially these are protein structures which help with the frequency of beating of the cilia, but also the motor function in terms of how the cilia move. So essentially in PCD we get problems with dynein arms either being absent or shortened, and therefore that causes the cilia to have abnormal movements, and therefore you get the clinical syndrome of issues with any organ which has cilia involved with it. And this table gives more of a summary of the kind of problems that patients with primary ciliary dyskinesia can face. So clearly ear issues, nasal problems, all of those issues relating in the lung, particularly bronchiectasis. In certain patients, there can be an issue with infertility because of cilia in the genitourinary tract. And then, of course, you've probably seen cases of the likes of cartilaginous syndrome or situs inversus, which is something which is associated with some patients with PCD as well. Other rare things which I have personally not seen before, but are definitely documented. So there are some cases of hydrocephalus and things like retinitis pigmentosa, also associated with PCD. So it's an autosomal recessive condition, and the prevalence is about 1 in 20,000 births. But if you diagnose it as in this patient who is diagnosed on the basis of their nasal biopsy and ciliary study findings, then the management is essentially standard bronchiectasis management. But clearly we also have an additional strong focus on the upper airways, particularly nasal symptom management. Patients need to have a lot of focus on hearing as well, and they may have sequential audiometry in some cases if that's appropriate. And of interest, just so you're aware, PCD is becoming a nationally commissioned service, like cystic fibrosis, and therefore there are hubs which are starting to develop around the country, of which Leicester is one of those, which is a commissioned centre for PCD care. The next case is a 49-year-old woman who's been referred with bronchiectasis with a history of recurrent chest infections over the last 40 years. Usually has about 4 or 5 infections per year, but also of interest has an occasional urinary tract infection. On sputum analysis, she turns out to have colonization with Haemophilus influenzae, MRC Dismiss score of 3, and no upper airway symptoms or hearing loss or anything to suggest respiratory distress as a neonate. So you got to think, really, what would you do next if that was your patient? What kind of things would you be thinking about in terms of further investigations or possible cause of bronchiectasis? Well, clearly we're going to think about our standard investigation pathway. We certainly want to exclude cystic fibrosis. And in terms of management, clearly physio and pulmonary rehab would be appropriate given this patient's MRC Dismiss score. But actually, this patient, the clue was really with the not just respiratory infections, but also urinary tract infections, that this patient actually has a low IgG level, which is in keeping with, in this case, a diagnosis of something called CVID, which warrants referral to the immunology team. And CVID stands for common variable immunodeficiency, which is the most common primary immunodeficiency that we see, affecting about 1 in 25,000 Caucasians. And in terms of management, as with most causes of bronchiectasis, standard optimized care for bronchiectasis, including probably having a lower threshold for using antibiotic prophylaxis in these patients. There is an association with CVID and the development of lymphoma and other conditions such as B12 and folate deficiency, so it's important that we think about having some way of monitoring for those. And I've put sort of question marks around immunoglobulin replacement therapy because there are sort of quite a few European immunology sort of guidelines, but I think the sort of consensus from immunologist to immunologist does vary, and you may find that whether or not these patients have immunoglobulin replacement therapy will depend on the setup of your local immunology service and the opinion of your local immunology team. So there are quite a few immunodeficiencies that we do come across. So things like CVID, which we mentioned, X-linked agammaglobulinemia, SPAD, which stands for specific polysaccharide antibody deficiency, and there are some patients who are labelled with something called antibody deficiency with normal total immunoglobulin levels. Clearly, all of these patients need to be seen and followed up by our immunology colleagues. And I guess the ideal setup for most bronchiectasis specialist services will be to have some parallel service working in conjunction with the immunology team. What is probably more interesting from our point of view as respiratory physicians is the fact that there's quite a few conditions which can cause secondary immunodeficiency. And as a consequence, we do see people with these conditions presenting with either recurrent chest infections or bronchiectasis. So things like hematological malignancy, post-transplant patients, but for some reason we see that more commonly in our bone marrow and renal transplant patients. Anyone who's got some drug-induced immunodeficiency, and of course, as we mentioned before, HIV is associated with the development of bronchiectasis. The next case is a 60-year-old woman who has a background of rheumatoid arthritis. She's known to have lung nodules due to her rheumatoid on long-term methotrexate. So she presented with 20 mils of hemoptysis acutely, along with green sputum, which was new. She had 2 previous similar admissions, but on this occasion things were certainly a lot worse. And she had this x-ray done. Actually, this was the first time that we had seen this patient. She had presented previously to other centres. And as we can see on the x-ray, there's clearly bilateral changes, and on the x-ray suggestion of bilateral cavitation, but particularly this really large cavity in the right mid-zone on the x-ray. And this was also associated with an anemia and a raised CRP level. So we can see on the CT scan of this patient, it certainly confirms features of bronchiectasis, but also bilateral cavitation, but particularly this really large cavity in the right lung. So as with all patients that we see with cavitation, we have a standard sort of differential diagnoses that we must consider, including cancer in particular, but also infections, including fungal, aspergillomas, atypical infection, and of course bacterial. So I guess the question is, if that was your patient presenting with those symptoms, what do you think you might do in the next steps of managing the patient? Well, for our patient, she actually had workup to exclude lung cancer, and that did include bronchoscopy. On lavage, we found that she had quite a significant amount of candida and also Pseudomonas. And in terms of screening for ABPA and fungal disease, those investigations were actually normal. So the patient was treated, but then admitted with massive hemoptysis subsequently. So I guess the question is, how would you deal with the situation then? Well, we know that she's got Pseudomonas and Candida, so she was treated quite aggressively for those organisms with anti-Pseudomonal IVs, as well as oral ciprofloxacin on top of that, and fluconazole. She was given tranexamic acid in view of the hemoptysis. Also had a gluten savages in case she needed transfusion. And she did actually need bronchial artery embolization because initial standard medical management was not enough to suppress the hemoptysis. And eventually she was referred back to a rheumatologist as she'd been lost to follow up prior to that. And that's really part of the reason, I think, why she presented with such quite terrible cavitation relating to her rheumatology, rheumatoid nodules, which is eventually what we diagnosed her after excluding other sort of reasons for that sort of significant horrible cavitation. Our fifth case is a patient who's got normal CT scans, so no features of bronchiectasis anatomically, but certainly has recurrent chest infections, has had previous pneumonia, and sputum demonstrates consistently growths of Haemophilus influenzae and Streptococcus pneumonia. Immunoglobulin levels have been normal, as has other testing, including HIV testing. So this is a case of somebody who's raising alarm bells because of the recurrent nature of the infections, and also the sort of phenotype of the microbiology, the types of samples that she has, Haemophilus and Streptococcus. So although the CT scan is normal, this should sort of warrant some further investigation as to what's causing these presentations. So in terms of other tests that may be useful, well, this is a sort of case where we would probably use our testing for pneumococcal IgG serotypes. So that's a blood test that can check a whole panel of IgG serotypes, and if we have a significant number of IgG serotypes which are low, then we can offer patients the Pneumovax, which is the vaccine, and then retest those blood tests a few weeks after that. And if we have an inadequate response despite Pneumovax, in other words, the IgG serotype levels are not improving after the Pneumovax, then the patient should be referred to our immunology colleagues. Similarly, we can check for Haemophilus influenza B antibodies, and if they're low, then again, immunology referral would be warranted. And this is the last case of this presentation. It's a 72-year-old man who's got known COPD and has recurrent growth of Pseudomonas aeruginosa. He's having about 4 or 5 chest infections per year for the last couple of years. and has an MRC DSIP score of 4. And this is the kind of typical referral that we sometimes get from other clinicians, including primary care. And in this case, the question is, should this patient be started on a long-term macrolide? So this is a patient who's not got bronchiectasis, but he has got COPD, but certainly he's got this phenotype of recurrent infections with Pseudomonas colonization. So we do see this quite often now in patients who have this sort of phenotype of what sounds and feels very much like bronchiectasis, but actually they have a normal CT scan or they have some sort of other airways disease such as COPD. And really the management approach for these kind of patients should be very similar to our other patients with established bronchiectasis, which includes clearly standard physiotherapy, airways clearance, pulmonary rehab if appropriate. But in terms of whether or not we start a macrolide, well, clearly it sounds like that may be a good idea, but we want more information before we do that. So it's important to get a baseline CT scan, which may be useful for looking at future bronchiolitis. Clearly, we want to think about any reasons why we couldn't start a macrolide, so we need to know baseline LFTs, we need to know the ECG QT interval, and also the patient needs to have screening for non-tuberculous mycobacteria. And certainly in our older patients, we're a bit more mindful of issues with hearing, which can actually be a problem or a side effect of using long-term macrolides. So if somebody is predisposed or they've already got significant issues with hearing loss, it may make you think twice about using a long-term macrolide. And then if we do start a macrolide in this patient, the next question is how long for? And again, there's no real evidence at the moment to say, what is the sort of specific duration of treatment. Some patients we give 2 or 3 months treatment and then stop and then reassess. But we do always come across patients who seem to be on it indefinitely. And I'm not sure if that's the right approach or not. Certainly, some patients are having what's called azithromycin holidays, which means that they have a stop of their macrolide azithromycin during the spring and summer months, particularly when there's less exposure to conditions which might be worse or make infections more likely, particularly in the sort of autumn and winter months. But again, there's no definite consensus on whether or not that is the right approach. So certainly food for thought. So just to summarize, really, that case is highlighting this sort of normal CT phenotype, but very much, clinical features of bronchiectasis. And we see that quite a lot in COPD patients, but also in our patients with secondary immunodeficiency. So in summary, there are a few major clinical phenotypes to consider. Of course, this is not an exhaustive list, but it's just trying to highlight the major phenotypes of bronchiectasis that we typically see in our clinic. So clearly there's a post-infectious or post-infection group, and they can present at any stage of life depending on when the infection affects them. Of course, there's genetic causes, of which CF is the commonest cause, but also primary ciliary dyskinesia is also something that we see in quite a few of our patients. Immunodeficiency, association with inflammatory conditions such as rheumatoid arthritis and inflammatory bowel disease. And then we have the microbiological phenotypes, of which Pseudomonas colonization or NTM are very common. And of course, as we just mentioned, the normal CT sort of phenotype. So just a few pointers and a few tips in terms of thinking about bronchiectasis as being a potential underlying diagnosis. Should always think about it, particularly if you have patients who have been labelled as asthma without any great objective of asthma, particularly lifelong symptoms. We should think about bronchiectasis in clearly any patient that's had a history of severe chest infections early in life, in all the patients with lifelong chest infections, in patients with nasal or ear symptoms, any patient that gives a history of having respiratory distress as a neonate, being admitted to the special care baby unit, any patient with recurrent chest infections or other system infections as well, pointing towards some sort of immunodeficiency potentially. And of course, as we mentioned, our patients with normal CT scans, but those organisms such as Haemophilus or Pseudomonas that we'd more commonly associate with bronchiectasis. And anyone who is going to be predisposed to secondary immunodeficiency, including previous transplant patients, also patients with inflammatory bowel disease or rheumatoid arthritis, and of course, as we said before, patients with COPD and recurrent infections. So just to remind ourselves, this sort of summary approach to investigating people with bronchiectasis, certainly doing immunoglobulins and HIV tests as standard is important, as well as ABPA testing and sputum for both routine culture and NTM. And we tailor our approach with the other investigations depending on what the history is. And management overview, really this is a very simplistic view, and of course you're going to have a much more detailed presentation of management, but just to sort of summarize, really clearly we want to treat the underlying cause. We want to have an antibiotic plan or self-management plan for dealing with infective exacerbations, but also considering long-term antibiotic prophylaxis in patients with frequent chronic infections. Really importantly, physiotherapy for airways clearance, but also potentially nasal management as well. Pulmonary rehab may be appropriate in patients who are more breathless. And of course, our supportive measures, including vaccinations and possibly bronchodilators, and some mechanism for regular sputum surveillance. So, in a nutshell, summarizing all of the causes, or actually the majority of causes of bronchiectasis in one slide, we can think about the three major groups at the top of the sort of slide, which is post-infective, immunodeficiency, or mucociliary clearance defects, or our genetic causes. And then, of course, there are a whole host of other less common causes that we do come across, particularly if you're working in a large bronchiectasis clinic. I'm going to finish there, and thank you very much for watching.